All right, how we doing? So the next presentation in our series is a relationship between polypharmacy and falls. Falls is a major problem in a nursing home environment. It's also one of the highest causative factors for lawsuits in the nursing home environment. So we're going to talk about this and talk about some cardiac causes that can ultimately kind of get you guys off the hook when a patient has a fall. My name is Mike Herringshaw, by the way, a nurse practitioner with the cardiology program. I'll be doing this presentation. All right, falls. So we're going to start with some legal data, some statistics and legal data. I like to do this because it kind of hits it home so you guys can understand how important it is to kind of manage this and keep an eye on it. So among those over the age of 65, 30 to 40% have had a fall, with 50% of those over the age of 80. So we can agree that this definitely applies to our patient population. 700,000 to 1 million acute care hospital stays. So all patients over the age of 65 has resulted in almost 1 million hospital stays because of a fall. It results in a cost of $34 billion a year. So anything that costs that much and is resulting in that much of a cost, you can promise that Uncle Sam is keeping an eye on it and definitely tracking it. In nursing homes in general, a 100-bed facility typically has 100 to 200 falls per year, ranging from 10 to 20% per quarter, according to a National Council on Aging. So, I ask all the facilities when I do this presentation, every single facility I've done this presentation at, it's actually higher than that. So it's always been higher. Fall injuries are 8 of the top 10 legal litigations against nursing homes. So a little stats. It's estimated there'll be 3 million SNF residents by 2030. So obviously the land will flow with milk and honey. Your beds will be filled, but it also comes with a greater liability and a greater responsibility. 50 to 70% of elder residents have a fall each year. This is twice the rate than those elders that are living independently. So you got to kind of take a moment and see how that's going to present in court. So basically what that statistic shows is that if they're at home living independently on their own, they have less of a chance of having a fall, is how they're going to try to present that. Roughly 35% of falls are with residents who can't walk. Think about how that looks if you're a juror. So wait a minute, we got a patient that can't walk. So if they're falling, obviously you must have dropped them. That's how they're going to try to present that. Approximately 1,800 residents per year die due to falls. Obviously, family members don't want their patients, or don't want their mother, their father, our patients to fall and have, resulting in a death. So we're going to definitely want to do our due diligence to try to prevent falls as much as possible. Average cost is $14,000 per fall. So every little fall that you send a patient out, every little fall that the patient has, on average, it costs $14,000. That adds up. So what do we need to do? First thing we need to do, and the same thing they do in the hospital, so we need to start doing it here, is identify patients that are high risk for falls. I can tell you this. Almost all your patients in your facility are high risk for falls. Have they had a previous fall history? Have they had a fall before? Have they had multiple falls? Do they fall all the time? Definitely going to want to keep a close eye on them. Use of psychotropic medications. So they did a randomized study at 10 facilities with over 100 falls and showed 100% of those residents were on a benzodiazepine. 100%. That's an absolute. We don't get a lot of absolutes in medicine. Anytime we do get an absolute, we definitely want to pay attention to it. So this is telling us that patients that are on benzodiazepines, a lot of our patient population, are at extremely high risk for having a fall. Incontinence. So patients that are incontinent will try to rush and get up to go to the bathroom, ultimately tripping and falling and having issues with that. Decline in functional status. A lot of patients are here for rehab. They have a change in functional status. Maybe they got a new knee or new hip. They're not used to it. They're used to hopping up out of bed and running to the bathroom. They hop up out of bed with that new knee. It doesn't work like they're used to, and they fall. Or they had a long hospital stay. They're weaker than they used to be. They don't have the strength, so they try to get up and ultimately resulting in a fall. Poor vision. So vision declines With age, if you can't see well, you're at higher risk for tripping over objects and having a fall. Use of cardiac medications. That's why you need to get cardiology involved with your patients. A lot of the medications we give to help them also increase the risk of falls. Some of the most common ones, ACEs and ARBs that we use for blood pressure management, diuretics, beta blockers, all of those increase risk for fall. A lot of them result in orthostatic hypotension. Polypharmacy. Polypharmacy is designed as simultaneous use of multiple drugs for multiple ailments in a single patient. 10 to 20% of falls are related to medication. 20%, 1 out of every 5 falls is related to medications. Bring cardiology in, let us get involved and sort out the mess with medications. Impaired cognitive status also can result in falls. Some patients don't have the cognitive knowledge to realize that they can't walk. They're not capable of walking, so they'll try to get up. Recent orthopedic injuries, we kind of already discussed that. Use of adaptive equipment. So the equipment that we give patients to help them not fall sometimes fails and causes them to fall. I've had a morbidly obese patient that I saw because she broke her hip. She was using a handrail in her bathroom to pull herself up. The rail ultimately broke off the wall, resulting in her falling and breaking her hip. I've seen walkers, get bound up on a cord or a little bump or something, and then the resident fall over top of the walker. Canes sometimes slip out from under them. So adaptive equipment can also increase risk for a fall. Pain. So severe amount of pain. We don't think right. We don't do things slowly. We don't do things cautiously when we're in pain. Changes of routine or environment. Excuse me. So sometimes we may change around the facility and update it and remodel it or reposition beds in the room or change the furniture. That definitely increases risk for falls, especially patients that can't see well. Those patients may be used to stuff being positioned in the same place all the time, and ultimately if we move it around, they can't see it well, they can ultimately trip over it and fall. So here's a little mnemonic that you can use when you're trying to identify a patient that's high risk for falls. It's called I hate falling. I being inflamed joints, H being hypotension, A auditory and or visual impairments, T tremors, especially patients with Parkinson's disease, E equilibrium problems, vertigo or Meniere's disease, F foot problems, A arrhythmias, heart blocks, valvular heart disease. Notice those are all cardiac diagnoses. L, leg length discrepancy. We have patients that have different leg lengths from time to time. L, lack of conditioning or generalized weakness. This is our skilled care patients. They're coming in here because they're weak, because they have lack of conditioning, because they need physical therapy. So they're definitely at risk for falls. I, any acute illnesses. N, nutrition problems, anorexia or failure to thrive, so they're going to be weak and not have the energy, the nutrition needed to be able to adequately walk. And G, gait disturbances. So ask not what you can do for cardiology, but what can cardiology do to help you. So we actually have some technology and some stuff that we use that helps out with this process, at least with the medications. So we're doing pharmacogenetic testing. I do it on all of my patients. Basically what that does is uses DNA from a patient to individualize the medical therapy and optimize medications for that specific patient. Up until pharmacogenetic testing, we have used evidence-based practice to prescribe medications, and it's not necessarily wrong. So we have a specific diagnosis that we've used evidence and research to give a specific medication to treat it. Here's the problem with that. Anytime we do research, any study, there's always a responding group that does well with it, but there's always that part of the study where the people didn't respond like everybody else. And that really never has been addressed before. So basically, anytime you do a study, and it's considered a good study when the drug that you're testing, that the majority of the group did well on. Pharmacogenetic testing allows us to address that group that was kind of forgotten, that group that didn't do well on the drug. So sometimes we put patients on medications that they don't respond well to. They may not have the receptors to metabolize the drug, or the receptors may not respond appropriately. They may metabolize the drug very rapidly, or they may metabolize the drug slowly. So pharmacogenetic testing will allow us to iron that all out. Basically, we just swab their cheek, we send it off to a lab, we get test results in about 4 weeks. The great thing about these tests is it not only tells us the DNA effects and how the receptors are responding to medications, but it also checks drug-to-drug interactions. It uses the Beer criteria, it uses risk stratification, all sorts of stuff to help us to really optimize the patient's medical therapy. Here's an example of a patient. So notice if you look to the left, basically our goal is to get everything down around 20, definitely less than 30. So if you look to the left versus the right, the left is what it was before we made medication changes. This is, and if you notice the protonics, there definitely is a genetic component with protonics, that wonderful royal blue color. So we changed around all the medications. The system actually gives us medications. It tells us what medications works best for the patient. So it doesn't just tell us that the medications aren't bad, it also gives us options to change it to medications that work. And if you notice to the right, after we went through all those medications and fixed it, the risk stratification is much lower than it was before. Other things that we can do to help with falls, we have cardiac event monitors. Basically, this is a USB drive with a sticker. We place it on the patient's chest. They can wear it in the shower, which is great. It requires no immediate nursing intervention. I'll put the sticker on the patient's chest. I will take it off when it's time to collect it. It's all you guys need to do is make sure the patient doesn't take it off. They can shower with it on. This is basically recording the electrical activity of the heart the entire time that's on the patient's chest. This will help us detect arrhythmias that sometimes are huge causative factors for falls. A little bit more details on event monitors. So we do it for about 7 days, sometimes a little bit longer, depending on when I get back to the facility. Generally, I'll put it on one day while I'm at the facility, and I'll take it off the next time I come back. Definitely, we use this event monitoring not only for mechanical falls, but also for syncope, unwitnessed falls. Sometimes we use it for chest pain, or sometimes just arrhythmias. So you got a patient with an irregular pulse, or sometimes a bradycardia. We'll put the monitor on and see what's going on. It's very easy to use. It's very user-friendly. Doesn't require a lot of nurse intervention. Really, the only thing I really need from you guys is if the patient, while they're wearing the monitor, gets sent out to the hospital or sent somewhere else, take the monitor off, because if it gets sent away and I don't get that USB drive back, the whole study's completely wasted. I have to be able to collect that USB drive to download all the data. All right, so that concludes our presentation on falls. If you have any questions or concerns, feel free to give me a text or call me. Thank you very much.